very much, Dr. Abdullah. We will take the questions at 11:20 a.m. inshallah. Our next speaker is our international guest speaker, Dr. Dan Sizemore. He is Associate Professor, Division of Health Policy and Management. He is the Director of the Master in Healthcare Administration Program at the University of Minnesota, USA. He has a 25 years experience in the provider side of health care delivery. He is a graduate of health psychology and health services management from University of Minnesota. Dr. Sizemore has led a sizable number of large-scale health systems and medical practice integrations, as well as specialty-focused health hospitals, physicians, partnership, and joint venture formation. He maintains consulting and advisory relationship with Essentia Health as well as with several other large U.S. health systems. He has a special interest in executive and physician leadership education. He is going to use this wealth of experience to talk to us about how U.S. health systems are approaching innovation for reforming healthcare market. Welcome, Dan.
There's two of them here. No, it's the other one.
There's no.
Hear me now? Good morning, everybody. I bring you greetings from our colleagues at the University of Minnesota. It's my honor to represent the University of Minnesota Master's Degree Program and our Executive Studies Program. I see a number of our students in the audience. We are very pleased and honored to have a partnership with King Fahad Medical City to help you develop your next generation of leaders. Especially grateful to Dr. Altamini for inviting me here today, and to Dr. Alamro for his leadership and our partnership together. So I have the pleasure of coming here multiple times during the year. It is one of the most pleasant things I do. So thank you very much for allowing me to be here to speak about innovation today. My two objectives here today are to talk to you about why innovation and how innovation in U.S. healthcare systems. I think my talk will follow Dr. Amro's quite well, in that he did a fine job of setting the stage for innovation on a global scale. And what I hope to do for you this morning and then later on this afternoon is bring it to the practical from the perspective of what are U.S. healthcare systems doing, and perhaps some of those activities could be useful to you as well. I would start by saying that innovation as a management tool in healthcare in the U.S. is quite new. In fact, probably one of the things you'll gather from many of the talks today is U.S. healthcare systems have, in fact, been behind the curve in innovation. Frankly, in U.S. healthcare, and I've been in it all my career, we like to do the same things over and over again, and we find the same way. And we find that in a healthcare environment of reform, and I'm going to set my talk in the context of reform, both legislative reform, but also economic reform and clinical reform in the U.S. I'm going to talk about how innovation, as Dr. Alamo said, is being taught, and it's being used now as a principal management tool. Many of my colleagues will follow and reinforce this. So the challenge for the U.S. healthcare systems in a reforming marketplace is that we are continually under pressures for total costs of care. You will find, when you look at our performance in the U.S., we do not rank highly on a global scale with respect to health status of our population. We rank typically somewhere down in the 30 to 40th ranking on healthcare status of the U.S. healthcare systems, yet we typically lead the world in how much money we spend on healthcare. The healthcare cost inflation rate in the United States is unsustainable, and that is in part what has led to legislated healthcare reform, but also reform is being driven a lot by the clinical care needs and the economics of healthcare. You will find that we are looking now more at innovating around the total costs of healthcare and not just simply the healthcare event. So one answer to this challenge is organized and funded efforts to innovate. You will find that many of the largest, most prestigious health systems in the United States have in fact begun to fund innovation centers. As Dr. Alamo said, these are not centers that come up with inventions. These are incentives, or these are centers that help the organization make process better, more efficient, leading to more cost-effective, higher quality health care. So I'm going to focus on the process of innovation and the management of innovation, how health systems are approaching innovation, and some of the things we're beginning to think about when we innovate. And then later in today, I'll provide some actual case studies for you. So, as Dr. Alamo said, for purposes of today, innovation is defined as the creation of an idea with implementation potential that has utility. It satisfies an existing need, is replicable, and economic. While all innovations may be inventive, all inventions are not innovations. So when I talk about the concept of innovation today in the context of health systems, it is really all around the practical. How we can take a good idea and take that idea and turn it into value for the health system and value for the patients as quickly and as economically as possible. I was also pleased to hear Dr. Alamo talk about the need to think about innovation from a cultural perspective. There was one organization, I believe it was IBM, the CEO of IBM at the time said, you know, we're not moving forward enough faster, not moving fast enough with new products. We need to learn to fail faster. So I want my innovations teams to go out and fail faster. We will learn more from our failures than we will from our successes. So you will see in healthcare systems, and leaders of these innovation centers are here with us the next 2 days. But health systems are beginning to fund the concept of innovation. It becomes part of the budget of the healthcare system. It is not, by the way, the only place where the good ideas come from. It's the place where the good ideas go to become developed. So you will find that innovation centers have become part of operating budgets. They're becoming part of capital budgets, and they're becoming part of the culture of U.S. healthcare systems so we can innovate faster, more effectively toward goals of the organization that create more value for the healthcare consumers and for those who pay for healthcare in the United States. So I'm going to start by talking about what is a center of innovation. Then I'm going to talk about what sorts of products these or processes and ideas they're working on, and how they really meet the needs that are very practical in health systems like ours and yours as well. As I said, I've had the pleasure of visiting here multiple times. We have some very fine students from the organization, and what I found in my first visit is many of the challenges and the problems that you face at KFMC are no different from the challenges that we face in the United States in delivering more cost-effective, value-based health care. So at least we're all in this together. So what are these innovation centers? They tend to be clearinghouses for new ideas. Ideas come there, ideas are evaluated, and they're evaluated against the strategy and the goals of the organization. They're not simply a place where new ideas go to be invented. They're very practical, they're very strategic, and they fit the overall goals and needs of the organization. These are also the point of approval, where money and funding is put behind these, and they become sort of the house and the proving ground, the laboratory, if you will, where new ideas go to be developed, and as you learned in the previous presentation, translated to the rest of the organization so it can then become commercialized or used widely within the organization. This is where senior leadership gets connected with new ideas. Good ideas, believe me, do not always come from the top. I can assure you, when I was the leader of a large care organization, most of the good ideas didn't come from my office, and most of the good ideas didn't come from the people who worked for me. It came from the people who were on the floors every day delivering care to patients, or from those who worked in the back offices and in finance. The bottom line here is that innovation has become well managed. It is becoming and innovation is becoming part of the culture of U.S. healthcare systems, and it's no longer something that just happens in the back room. So what I want to talk about now is some of the common characteristics of these innovation centers in health systems. Probably the most important finding that many of the U.S. healthcare systems really have come to appreciate, as Dr. Alhamro said, most of the good ideas, in fact, are not coming from the physicians. They're coming from the pairing of physicians and other clinicians with folks who typically have not been part of healthcare delivery, mostly engineers. And they can be process engineers, but they are technical in nature, and they are taking their expertise, their training, and they're marrying it with the healthcare providers to take new ideas and turn them into practical, translatable innovations. But what's driving this? I mean, we could say, but if healthcare works, why are we fixing it? Well, the fact is, much of the healthcare delivery in the U.S. is not working as effectively as it needs to. It is still quite fragmented. In many respects, you are more organized here at King Fahd Medical City than many of our own healthcare delivery systems. But what are the drivers of innovation? You may say, oh, innovation is good, and I guess we should all do it, but what's the practical side of it? What's driving innovation? Total cost of care. Total cost of care is a relatively new concept being adopted by health systems. And this is not the issue of price. This is not the issue of how much does a unit of care cost. The issue is, what does it cost to manage and take care of patients over time? Upwards about 73 to 75% of the healthcare costs in the United States are driven by chronic conditions or chronic diseases. We tend to look at healthcare in the United States as a connection of events. Somebody comes for a heart surgery, somebody comes for a hip replacement, somebody comes to have a baby. We in healthcare delivery in the United States have tended to look at healthcare cross-sectionally, where the innovation is really around looking at healthcare longitudinally. the ability to manage populations of people over time. And if you look at some of the chronic conditions we are facing in the United States, they are no different than some of the chronic conditions you are facing here. Diabetes, for example, obesity, for example, vascular disease, for example, much of which is lifestyle-oriented, some of which is genetically predetermined, but most of it is behaviors interacting with genetics. But our healthcare system has been, as I said, more cross-sectionally oriented, and we need to think more longitudinally, and we need to innovate around better outcomes at lower costs. It was said, in fact, this week that upwards of $200 billion of our annual Medicare budget, which is in a governmental line item, goes for care that's unnecessary, care that's wasteful, care that's duplicative. So you will find that many of our innovations right now are focusing on total cost of care management and retraining our thinking from the episodic event to long-term management of populations to create better, healthier populations. So much of the innovation that's going on in these innovation centers is focusing on population health, improving the health status of populations. Right now, we have an epidemic of childhood obesity in the United States. Left uncared for, left unattended, that's going to escalate the annual national health care budget, perhaps more than any other epidemiologic occurrence that we've seen in several decades. There's innovation around health informatics, the linking of healthcare in IT people with clinicians, translating data into knowledge that can be acted upon. We often say in the healthcare systems in the United States, we are data rich and information poor. So much of the innovation has been focusing on taking millions of data points and actually translating it into information that clinicians can use to make, and management can use to make decisions. So much of the innovation is focusing on this area of healthcare informatics. Innovation centers are also focusing on evidence-based best practices, the determination of best practice clinical pathways in their dissemination through an organization. One of the sort of novelties of the U.S. healthcare system over the last several decades has been the aggregation, consolidation, and integration of healthcare systems, creating multi-state national health systems. But in fact, what we've failed to do is change the behaviors of those health systems so they provide a standard level of high-quality care across sites in a system, whether it be the Cleveland Clinic or whether it be Mayo or whether it be other large health systems in the United States. They're beginning to think more across sites rather than simply within sites. So you will find a number of the innovation centers focusing on evidence-based best practices. Likewise, the reduction of process variation. We used to have a saying in the United States that all health care is local, meaning however you do it, where you work, is the best way to do it. And what we find is we provide health care to the same types of conditions and people differently across sites, using vastly different arrays of resources and spending far too much. So much of the innovation is around reducing process variation, reducing variation between clinicians, reducing variation between sites, trying to find evidence-based, one best practices to do certain things. Learning to leverage resources in short supply. One of the things I find, which is here in Saudi as it is in the United States, we have shortages of high-quality, highly trained clinicians. So much of the innovation is around what we call leveraging the provider. So let me give you a very practical example. In the average primary care patient base in the United States, there has typically been about 2,500 patients. I know in the health system I operated, most primary care physicians would have upwards of 2,500 patients in their patient panels. Many of these health systems, because of the shortage of physicians, especially primary care physicians, are saying these patient panel sizes must triple. So we'll have family physicians, for example, with their patient bases moving from 2,500 patients to 7,500 patients. Well, how do you do that without innovation? The fact is, you can't. So we're seeing care model innovation that allows people, and this is sort of a new term of art in the United States, allowing physicians and other clinicians to work to the top of their license, making sure that physicians do what physicians should do, what advanced practice nurses do what they should do, and we're finding now that clinicians, family physicians, and other primary care physicians may be managing from 2 to 3 what we call physician extenders, and the physicians may be caring for the very sick in that panel, and the less sick are cared for by other professionals managed and supervised by physicians. Another area of innovation we're focusing on is capital efficiency. One example of capital efficiency would be length of stay in inpatient, the ability to effectively apply the inpatient asset base to its highest level of efficiency. In the Twin Cities, for example, our largest open heart program has an average length of stay of about 3.9 days. So every 3.9 days, those beds turn over. So we're using the hospital assets far more efficiently, and the capital efficiency is becoming more important as healthcare becomes much more capital intensive as an industry, and the assets become obsolete faster because of new innovation and new invention. So you'll find many innovation centers working on leveraging providers in short supply and making the asset base far more efficient. Preventive medicine. This links together with population health activities, where we're trying to engage patients more actively in the management of their own health. And we're doing this in a number of ways by creating preventive care protocols, but also using such social media tools like Facebook to link patients with their health system for purposes of linking patients together who have the same conditions so they can be supportive of each other, and using these social medias to create more brand loyalty with the health systems. So health systems in the past in the United States have been focused on treating people as they show up. Some of the more innovative health systems are trying to manage populations of people to actually keep them healthier and keep them out of the health system, especially as payment reform changes. So patient behavior management, engaging patients with their healthcare providers differently, is becoming far more important, and we're using some non-traditional techniques and methods such as social media to do that. So you will find, for example, new startup companies focusing on taking the same approaches that have been used in airlines to create customer loyalty, using those same techniques to create patient loyalty. Well, why does that matter is an important question. Well, it affects the supply and demand, or the usage of health systems. We have facilities and resources in short supply, and we don't want to be wasting them either. So our ability to innovate around patient engagement and behavior management is important. So common innovation program management characteristics. They're not an effort for funding new inventions. These are not places where physicians show up and have a new idea for a gizmo or gadget and money flows into it. These are linked with the goals and the strategies of the organization. They must be ideas that help the organization move toward its mission, and move toward its strategy. These centers of innovation provide the resources, the talented people, and the management processes to take these new ideas, create the innovation, and move that innovation to commercialization within the context of the healthcare system. New ideas have to meet certain criteria. You will often find centers of innovation that will have return on investment requirements, which sounds a little bit antithetical, but if you think about it, a good idea or a good innovation is only a good innovation if it helps the organization move toward its goals and objectives. So consequently, you will have folks doing the return on investment analyses, and the innovation centers will provide the champions or the management that will help move the process forward. All projects succeed or they are formally closed out. Nothing just simply dies a slow death. Either we can move it to a very practical institutional translation, or we make sure the project doesn't go forward. So these are not just simply think tanks where, as I said, good inventions go to be funded. So who's funding innovation centers? Mayo Clinic, the Cleveland Clinic, which you'll hear about, Banner Health, Allina Health, Fairview University, the university where I am, Essentia Health. This is becoming a very important part of the management and leadership structure of health systems. So let me give you a few project examples, and then I'll come back later today and we'll talk about some actual cases that Dr. Altamini asked me to bring to you today. So to give you a flavor of what innovation centers work on, here are some. Use of electronic connection with patients to effectively modify their health behaviors and how they use the health system. I know from many of our students in class here at KFMC, they will say, we need to figure out better ways to manage patients' use of our scarce resources. As I said earlier, the use of multidisciplinary teams of physicians and other professionals, where the physician may be the team leader, but the physician is not alone in the team, taking much more of a team approach. Here's a very specific example in the Twin Cities. Many of the health insurance companies believe that spine surgeries are overutilized. So what clinical programs can we put into place that would reduce unnecessary spine surgeries? What are the innovations? What are the medical care modalities that we can try before moving patients to surgery? Innovations around reduction of readmission rates for heart failure. Many of the insurance companies are now refusing to pay if somebody is readmitted within 30 to 60 days of a discharge from the hospital. In other words, if somebody is discharged for heart failure, goes home unmanaged, does not take their medications properly, and within 30 or 60 days are readmitted to the hospital, the insurance companies won't pay for it because that is to be considered an avoidable admission. So many health systems, to their own economic benefit, are attempting to innovate around clinical processes that have direct connections to financial performance and economic success. Open access for physician appointments. I'm on an electronic health record. I can call up my own electronic health care record at home. I can schedule appointments with my primary care physician. Many times I get cared for by my primary care physician's team, and I never go into the office. It's all taken care of online. As I said, social networking to link patients together. Stroke patients, for example, heart failure patients, patients that have chronic conditions are linked together in these social networks, and they find that they're using far less healthcare resources, they're self-managing better, and in fact, their quality of life is improving. Incentive point systems. There's a very interesting, innovative company, a startup in the Twin Cities, and it's all made up of people who were successful in the airline incentive business. I'm sure you have your incentive cards with you. I don't know if you're diamond status or you're platinum status, but there's a whole psychology around that concept. And there's a very innovative company in the Twin Cities that is using those same techniques to create behavioral change among patients. Those are parts of innovation centers. Joint camps, bringing everybody that needs hip replacement together at the same time. Have them go to class together. Have them have their surgeries on the same day. Have them go to rehab together. And they find that those social interactions are reducing the level of pain, perceived pain, actually reducing the consumption of pain medications, dropping the infection rate, and improving the satisfaction rate of the patients having joints replaced, and related new approaches to pain management. Some of the metrics. An innovation is not worth anything in an organization like this unless it furthers the mission of the organization. So you need to tie innovations to metrics. What is important is measured in organizations. What's not important is typically not measured. Metrics must be tied to innovations, whether they be total cost of care, managing the costs for taking care of certain cohorts of patients over time, metrics around patient loyalty, metrics around reduction of unnecessary visits to the health system, metrics around unnecessary readmission rates, metrics regarding patient panel size. So in conclusion, innovation is becoming a funded line item of medical centers. Before people who were innovative had to figure out how to fund this themselves. This is the first time in my career, as I said, where I'm seeing line items in operating budgets for innovation centers. Money is being allocated, people are being hired, new types of skills are being brought to health system. It's become an organized approach to moving the organization by harnessing the good ideas of people like you and bringing them to fruition in organizations in a very, very practical way. Health systems are importing new competencies to effectively manage this process. Engineers, industrial engineers, process engineers, for example, are becoming part of the staff of health system. Innovation efforts are resourced to further, as I said, the goals and the objectives. The hard business of innovation is it must make sense. It must further the goals of the organization. And as was said by Dr. Al-Amran and myself, we're not simply throwing money at new inventions. This is a necessary part and an efficient part of moving organizations forward. Investments in innovations rise as health systems are subjected to new reimbursement schemes. As I suggested, the U.S. healthcare system is under extraordinary pressure to reform itself right now, to change itself for the better. We're going to have to do that with far less money. We spend far too much of our gross domestic product on healthcare. I think we're probably up to 18% of our gross domestic product is on healthcare. And every reasonable, rational study I've seen on healthcare in the United States would suggest that upwards of 30% of all the healthcare we provide does no good for anybody and even perhaps does harm. It is time for innovation in healthcare delivery in the United States. So in conclusion, it is a privilege to come here. It is especially energizing for me to see a high-quality organization like this have a conference like this. You would not see a conference on innovation at every health system in the United States. It is very forward-thinking of your leadership to have a conference like this. It's a privilege to be here, and I'll be back later to talk about some cases for you today. So thank you very much for the invitation to be here.